Welcome back, ladies and gentlemen. Our next session will explore into the depths of infections affecting the central nervous system. This will be chaired by Professor Champika Bodhinayaka, Professor, Department of Medicine, University of Ruhuna, and Dr. Janaki Abenayaka, Consultant Medical Virologist of the Medical Research Institute, Sri Lanka. I invite Professor Bodhinayaka and Dr. Abenayaka to chair the session.
Good morning to all of you. Our symposium is titled Brain Battles, Tackling CNS Infections. And this will go as a case-based discussion, which will be moderated by Dr. Dilusha Lamabadasuriya. She will be introduced by my co-chairperson.
Morning again. So, for the session, our moderator is Dr. Dilusha Lamabadasuriya. Dr. Dilusha Lamabadasuriya, MBBS Colombo, MD Colombo, MRCP UK, is a board certified specialist in general medicine, currently working as a senior lecturer in medicine and an honorary consultant physician at the Department of Medicine, Faculty of Medicine, Sir John Katalawala Defence University. She graduated with first class honours from University of Colombo in 2008 with level gold medals and 4 distinctions. She is the immediate past Joint Secretary of the Sri Lanka College of Internal Medicine and is a member of the Expert Committee on Infectious Disease of Sri Lanka College of Internal Medicine. Over to you, Dr. Lamabadasuriya. Please welcome.
Thank you for that very kind introduction. So may I introduce our expert panel for this symposium on brain battles. So we are going to discuss very interesting 2 cases. So our first expert panelist is Professor George Varghese. He is the professor and head of Department of Infectious Diseases at the Christian Medical College, Vellore. We also have Professor Tashi Chang. He is a senior professor of neurology at the University of Colombo. And Dr. Muthugala, who is a consultant virologist at the Medical Research Institute in National Medical Research Institute in Sri Lanka. So we'll be discussing 2 cases, interesting CNS infections. And the first of these cases will be presented by Dr. Pavitra Dineshan. She is a senior registrar in neurology. And I invite her on stage to start the case presentation.
Thank you, Madam, for the kind introduction. Today, we'll be going through a very complex case, and he has been managed for several years in our unit. So we'll try to make it simple and understandable as I go through the presentation. So my patient is a 29-year-old male, Mr. R.S., who is otherwise well, who had a history of imprisonment for 1 year, and he was released in April 2020. He's a 3-wheel driver by occupation. He's unmarried. His father was also in prison, and he lives with mother and his elder brother. And he's a social drinker and a smoker of half a pack a year. So the history goes back to 2020 April, where he presented with fever for 2 weeks, cough with white scanty sputum for 1 week, without hemoptysis, shortness of breath, loss of appetite or loss of weight. On examination, he was afebrile, there was no pain, not dyspneic, and the vitals were stable, and the saturation was also 98% on room air. On respiratory tract examination, right-sided lower zone, there was reduced movement, stony dull on percussion, and reduced air entry. At that time, the investigation showed normal counts, ESR of 61, CRP slightly elevated of 29, and normal liver function and liver function tests. And sputum AFB 3 times were negative. Bacterial culture of the sputum was also negative. MAN2 was 12 millimeter. Pleural fluid showed blood-stained appearance of 24,000 total WBCs with 55% polymorphs, 45% lymphocytes, protein of 6.8. Bacterial culture, there was no growth. ADA was normal. Cytology revealed mostly blood. I just want to show his chest x-ray, which he had right-sided lower zone haziness, as you can see there. And CCT showed small loculated pleural effusion on right posterior basal region, query empyema. So at that time, he was treated with intravenous antibiotics and discharged on oral antibiotics. And chest x-ray was repeated in 2 months, and you can see it has almost cleared whatever we have seen in the right side lower zone region. After 6 months, he was well and above. He again presented with progressively worsening generalized headache for 2 months with associated double vision with no vomiting, and a mechanical type of a lower back pain for 2 months where he denied lower limb numbness, weakness, or sphincter involvement, and there was no preceding trauma or history of heavy weightlifting. He had a fever with acute onset behavioral changes of 3 days, which has made him to come to the hospital, where he complained to talking to self, drowsiness on and off, poor oral intake, but he denied any seizures. There was background history of loss of appetite and loss of weight, which has been going for about 2 to 3 months. At that point, the examination showed GCS of 15 by 15. He was afebrile. There was no neck stiffness. Pupils were 3 millimeter, equally reacting to light bilaterally. Fundi showed no papilledema. There was right-sided 6th cranial nerve palsy, and lower back tenderness was positive. Otherwise, upper limbs, lower limbs, cranial nerves, other cranial nerves, and cerebellum were neurologically normal. So at 2020 November, the summary was the 26-year-old male previously evaluated for right-sided pleural effusion, presenting with fever and acute onset of behavioral changes for 3 days with worsening headache, diplopia, mechanical type of a back pain over 2 months in the background of loss of appetite and loss of weight. Neurologically, there was only right-sided 6th nerve palsy, otherwise normal. So we went ahead. The investigation showed full blood count was normal. ESR was slightly elevated of 29, CRP 4.9. Other renal liver functions were normal. Urine full report, urine cultures, blood cultures negative. Sputum TB PCR was also negative. As there was a neurological complaint, we went ahead and did the lumbar puncture. The cerebrospinal fluid protein showed very high of 155 with significant sugar drop of more than 60% and of a polymorphs of 38 and lymphocytes of 18. And his CSF TB PCR became positive without showing rifampicin resistance. The CSF bacterial culture was negative. We went ahead with the imaging, which showed basal meningeal enhancement with dural enhancement that you can see here in this contrast enhanced T1 weighted axial images of the brain.
Okay, Pavitra, let me just stop you at this point and maybe ask Professor Varghese, what are your thoughts on this case at this point? So there was a CSF report available, the MRI, and then TB PCR that has become positive.
Yeah, very interesting case. Young man with history of right-sided pleural effusion and a cough which occurred in April 2020 and in November 2020 presenting with a subacute chronic meningitis with sixth nerve involvement on the right side. There is clear evidence of basal enhancement And the diagnosis is fairly conclusive. The expert TB-PCR is positive with no RIF resistance. This is something which we see commonly, but there are some alarming features in this person. Two things. Can you just go back to those CSF findings? The polymorphs, which is predominant, neutrophilic pleocytosis with sugar of 20 with an RBS of 100. When you see this, you would see this in two scenarios. Number one is very early in TB meningitis. So here, the diagnosis is not a question because the specificity of expert TB PCR is almost 100%. So the questions are, what are the unusual things and what are the indicators which tells us that he could be having a very severe disease. So as I said, this neutrophilic pleocytosis and very low sugar indicates an inflammatory response. Occurs in two situations in TB. One which is very early in the disease. In the initial few days, you can see this response. But then he actually presented with 2 months of headache. So obviously the disease has been going on for some time. He probably had a progressive disease. He would have acquired the disease or reactivated way back in April or even before that. And then presenting with subacute chronic meningitis. The other situation where you would see this is in a situation where there is a profound inflammatory response, which occurs in two situations again. Number one, when the organism load is high. When you see the TB meningitis is generally a paucibacillary disease. When you see miliary disease or organism load is high, you would see inflammatory response like this. And also, there are, generally people looked at the host factors which can give rise to an inflammatory response in TB. And they, zebrafish model and further human studies, they found that the LTA4H gene polymorphism, SNPs, single nucleotide polymorphism, is an indicator which will tell you, if you look at the phenotype and the inflammatory response and the chance for paradoxical worsening or the problems later. So this, the TT phenotype, where the homozygous for TT is hyperinflammatory. On the other hand, CC phenotype, which is hypoinflammatory, and CT genotype is balanced one. Now there is, when you look at the human data from different countries, from Indonesia, there is evidence showing that this is a good indicator of the inflammatory response, while studies from Vietnam and India does not really prove that that is a good biomarker for the inflammatory response and poor outcome. That is primarily because there are more than one factors which are involved, like I said, the organism load. So when I see this, I would start wondering, is this patient in for a paradoxical worsening and an inflammatory response? And today, in our setting, what do we do when we see this? We start off with the steroid, which is the, other than anti-tuberculous therapy. Anti-tuberculous therapy, you must remember that although we are starting with the four important first-line drugs, which are INH, rifampicin, pyrazinamide, and ethambutol, out of which pyrazinamide has the best CNS penetration, followed by isoniazid, ethambutol the least, rifampicin somewhere in between. So I would make sure that he gets adequate doses of these drugs. Rifampicin at least 15 milligrams per kilo, and pyrazinamide 25 milligrams per kilo, and with the other two drugs. Here it's a susceptible, rifampicin susceptible TB, so you don't have to worry about MDR TB. Good dose ATT, first line drugs, along with steroids, usually dexamethasone 0.4 milligrams per kilo is what one would use for treating this inflammatory response. The outcome, both in terms of mortality and the neurological outcomes, are better. So at this point, I would just start a good ATT and steroids.
Thank you for that. Can I ask Professor Chang, it was mentioned he had a sixth nerve palsy. What could be the reason for that, given the clinical history and imaging?
Well, as you saw, there is meningeal enhancement. So the sixth nerve is the longest nerve in the cranium, so it is most susceptible to injury. And also the increased intracranial pressure. So increased intracranial pressure is a hallmark feature in CNS tuberculosis, TB meningitis. So the increased pressure would cause a false localizing sign. So that would be the two causes, probably the inflammation at the base of the brain affecting the sixth nerve. But then the question is, what about the other cranial nerves? Why are they not involved? So I would think it is more the increased intracranial pressure that will account for this. And that also is reflected by his chronic headache that was going on. Just to echo what Prof. George said was, I mean, it is very crucial to understand that TB meningitis is so very different from tuberculosis elsewhere in the body. Simply for two reasons. One is because we have what is called a blood-brain barrier, and therefore the anti-TB medication do not penetrate as well as in other situations. And also because it is notoriously difficult to isolate the organism, because it's like Prof. George said, it is a paucibacillary disease. There's very little organisms in the CSF. But when it occurs, and now this sort of situation, the crucial thing about TB meningitis is the balance between the organism and the host immune response, the inflammatory response. Sometimes it is the inflammation that causes more damage than the organism itself. But of course, the organism is the one that provokes it. So now this sort of CSF should alarm someone that there is, at the very beginning, there's quite a profound inflammatory response occurring. And something that often people miss in the treatment is that they neglect the steroid part of the treatment. So, and as soon as TB meningitis is diagnosed, everybody feels comfortable in giving anti-TB medication. But the issue is not enough emphasis is given for the anti-inflammatory treatment. So here you need to give a good, reasonable dose for an adequate period of time to ensure that we do not go into problems later on. And as it was pointed out, we need a biomarker to see which patient actually needs a more profound treatment, a more aggressive treatment at the beginning in terms of inflammation. So the LTA4 hydrolase is a good biomarker, but it has not been validated enough for us to use it throughout. But of course, we need to take multiple factors into account. Now, for example, like the extremely low sugar and the polymorphs in the initial CSF. So these are kind of clues that tell us that here is a situation where there is quite a pronounced inflammation that is ongoing. The other thing I would like to add is about this gene expert. Although it's very highly specific, in the CSF it has not a very moderate sensitivity. So it doesn't have a very good negative predictive value. Like just because it is negative, you cannot rule out TB meningitis. When it is positive, yes, it's a fantastic test. But when it's negative, be cautious that you cannot rule it out.
Shall we see what happened to the patient after this, Pavitra?
So we also thought of CNS TB and we started him on antituberculous treatment and with high-dose dexamethasone starting from intravenous 0.4 milligram per kilogram. And the anti-TB treatment was given as a fixed drug combination of the 4 drugs. And on discharge after about 4 to 5 weeks, he had no behavioral changes of fever. Headache was settled but improved rather than what he was having before. So he was planned to get reviewed in the clinic after 1 month. But the things didn't go as we expected. He again presented with, after 1 month on the clinic day, he presented with recurring fever, headache, chills, and drowsiness. But there was no worsening of the focal neurological signs except the pre-existing right-sided sixth nerve palsy. And the higher mental function showed MMSE of 27 and MoCA of 23. So we repeated the CSF. I have given the 2020 November CSF also to compare. Still, the protein was very high, 175, with significant sugar drop. But this time, the polymorphs were massively high at level of 435 and lymphocytes of 48. But this time, TB PCR and TB cultures were negative. So we did the imaging, which showed significant parenchymal lesions with addition to the TB meningitis, and also MRA. Also, there was evidence of TB vasculitis. He also had a complaint of back pain, so we imaged his spine as well, where it showed TB spondylodiscitis at T12L1 level with small intravertebral abscess at T12 vertebrae. And CCT chest showed miliary TB. So we were wondering whether there is some underlying immunosuppression is also going because we adequately treated, but he became symptomatic again and there was worsening in the imaging finding and also in the lumbar puncture. So we did the retroviral studies and VDRL which were negative and flow cytometry showed low level of CD4 and CD19 which may be secondary to steroid use. The immunoglobulins were normal except IgM which was slightly low but not low as for an immunodeficiency. So we went ahead and had a discussion with the respiratory team and we wanted to change the anti-TB treatment to individual drug regime with separate high dose, weight related dose and extended intensive phase to further 3 months, and we decided to reassess the CSF and MRI to decide on the continuation phase. At the same time, we plan to tail off dexamethasone. Afterwards, in 2 months, again he had another complaint where he had progressive, painless, bilateral visual impairment for 1 week. The visual acuity was bilaterally 6/60 with reduced color vision, 1/38 on the right side and left side 0/38. Visual fields were normal and there was no relative afferent pupillary defect. This time when we repeated the lumbar puncture, it showed massive amount of protein of 336, with still there is a sugar drop going on with high polymorphs and lymphocytes. Still here also TB PCR and TB cultures were negative. We had to do the MRI imaging because he had a new complaint this time. This showed multiple tuberculoma around the optic nerve and involvement of the optic nerve itself. What did we do this time? We stopped the ethambutol because of the query. It may worsen the optic nerve involvement because there is a significant reduction of the visual acuity and ethambutol is known to cause optic neuritis. Even though in this patient it is not a direct cause, we just want to be cautious. And we treated with isoniazid, rifampicin, pyrazinamide and we added levofloxacin. With that, there was improvement in his vision and on discharge, bilaterally the visual acuity was 6/36. And over the course, he developed worsening headache and developed hydrocephalus, and we had to insert bilateral VP shunt. Afterwards, on follow-up MRI, his drug compliance was also good, and with the MRI imaging showed stable granulomas and basal meningitis, but the parenchymal lesions, there was interval resolution. Interestingly, when we repeated the MRI spine, the already existing T12 L1 spondylodiscitis and vertebral abscess was stable without spinal cord involvement, but there was a significant amount of right-sided Swartz abscess, 2 into 3 centimeter into 1 centimeter size abscess was found. And still we were wondering why this patient is again developing symptoms and there is worsening. We wanted to get the Swartz abscess drained, but the culture was negative. We managed to do a paraspinal lesion biopsy and it showed ill-formed granuloma and surrounding inflammation consistent with TB. So we went ahead and gave the anti-TB treatment at the doses that I have mentioned here, which was given up to 2021 June, which has been started from 2020 November. And after that, for 1 year, we continued isoniazid and rifampicin. So after 2 years of complete ATT treatment, we stopped the treatment because he was neurologically static, and follow-up MRI also showed there is interval reduction in the lesions and size and number of the lesions.
So at this point, I'd like to ask the panel if they're happy that all his symptoms were due to just CNS TB and the medical treating team had escalated treatment for TB gradually. They had gone on to second line CAT2 treatment as well. So is his entire clinical picture just explained by pure CNS TB at this point?
Well, I mean, it always brings a doubt into your mind when you look at this diagnosis. Are we still treating TB because the patient is now progressing despite the appropriate treatment? So you're thinking, could this be fungal? Could this be something else? But when you look at the whole picture, there's nothing else, and in our part of the world, this still has to be TB. The issue is what's different. Now, this is a complex case. From the very beginning, we saw a very reactive CSF, and if you saw the serial CSF, the protein was increasing, the polymorphs were increasing. Now, persistent polymorphs in the CSF in TB is extremely rare. It occurs in less than 10% of patients. Now, when it occurs, what it tells you is that there is quite pronounced inflammation occurring in the CNS. That is what it tells you. So the protein being high, a very reactive CSF, that means there's a lot of inflammation going on. And what is provoking this inflammation? So there are two aspects to that. Either the patient's immunity is not adequate to curtail this, or there is a dysregulated immunity, or the patient's bacillary load is quite high. And that is what is provoking it. So we have tested the rifampicin resistance, there is no drug resistance. So what then is happening here? So there is a abnormal inflammatory response which is very pronounced, and you can see the protein increasing, the cells increasing, and the patient's actually condition worsening. And compared to the initial MRIs, now you are seeing new lesions appearing. You are seeing tuberculomas appearing. So this is what is called a paradoxical reaction to TB treatment. Paradoxical reactions are not uncommon, they are fairly common, but what happens is that the majority of them are asymptomatic because we do not serially image our patients. If we do serially image, then often we would see new lesions occurring. As long as the asymptomatic and the patient is overall getting better, we don't mind. But in this situation, the patient is actually getting worse and there are new tuberculomas forming. And as you saw, the tuberculomas are forming over the optic chiasma, causing the patient to have reduced vision. Now, when this optic chiasma, when you have tuberculomas and the inflammation spreading into the optic chiasma, it is called optochiasmatic arachnoiditis. So that is a tuberculous optochiasmatic arachnoiditis, which is vision threatening. You can have irreversible visual loss. Now, in that situation, now in this patient, what we saw was the anti-TB medication being changed into individual medication. Now in Sri Lanka, for our Indian colleagues, in Sri Lanka, the TB medication is given by our respiratory physicians. So they are controlling the anti-TB medication, and often we get the combined pill. Now, what I feel is that in TB meningitis, we have to go for the individual medication, because I don't think the combined pill has the adequate amount of medication, because as I initially told you, the blood-brain barrier is the problem, because the penetration is so poor of some of the medication that we need to use higher doses than what is given in the combined pill. So that is what was done in this patient. But at that point, I think, when you see so much inflammation occurring, when you see the tuberculomas forming, then you have to start anti-inflammatory medication. So the anti-inflammatory medication that we can use at that point would have been high-dose steroids. So sometimes we use methylprednisolone pulses. Sometimes we use high-dose dexamethasone. And sometimes we also use other anti-inflammatory agents like infliximab or thalidomide. These are anti-TNF factor alpha, because what has been found in TB meningitis that has a lot of inflammation, in the CSF there are high levels of TNF alpha. And TNF alpha is a pro-inflammatory cytokine. And it has, some of the case studies have shown that using anti-TNF alpha agents help to reduce the inflammation. Now the question is, at which point do you start? Now, do we start this in all patients with TB meningitis? That will be an overkill. And it is a difficult balance, because you give anti-inflammatory agents, the organism will take precedence. It'll divide and cause more problems. So which patient do you actually start a very aggressive course of anti-inflammatory agents? So that is the crucial question in TB meningitis. And for that, we need a reliable biomarker. So as you heard, LTA4 hydrolase was alluded to, but there's a lot of ongoing studies looking for an ideal biomarker. And some people are looking at TNF alpha, interleukin 10 ratios, and so on. So pro-inflammatory, anti-inflammatory cytokines in the CSF. But to date, we don't have a reliable biomarker to tell us when do we actually step up to a very high level the anti-TB medication. But in this patient, given that now we are seeing tuberculomas occurring around the optic chiasma, causing optochiasmatic arachnoiditis, I would feel at that point, in addition to changing the anti-TB medication to individual medication, you also have to hit the patient hard with either methylprednisolone pulses or start with infliximab or thalidomide or all three together, because if you don't treat it early, then the inflammation progresses. And of course, it is a self-perpetuating sort of cascade. So once it sets in, then nothing will stop it, because then that inflammation will continue. So there's a point of no return, that is what I believe. So you need to address this early in the course.
Given that this patient had miliary TB as well, he had lung involvement, and that is not a contraindication to go for infliximab, is it?
Well, we were also very hesitant. There are studies looking at infliximab, both higher dose and lower dose. A few things, just to reiterate what has already been said. Number one is, right from the beginning, we would have started weight-based individual drug therapy, because this FTC, you cannot adjust the doses, and you want optimal doses, rifampicin of at least 15 milligrams per kilo, and pyrazinamide. You would give individual drugs optimized dose. When would I intervene is the million-dollar question. Number one, the time, November you started the ATT and steroids. December he developed vasculitis. There's evidence of vasculitis. At that point, we would probably start aspirin. When you see if there is an evidence of vasculitis, aspirin in the anti-inflammatory dose, which is 150 milligrams, not 75 milligrams, which is antiplatelet activity dose. 150 milligrams you would start at that point, December 2020. By February 2021, he clearly developed optochiasmal arachnoiditis, tuberculosis, basal, tuberculosis, all that telling you with worsening CSF, clinical deterioration, all that is telling you that this person's host inflammatory response is the one which is causing the problem. You need to intervene. Today, we would intervene by March, April 2021, we would have given infliximab. The evidence is reasonably there. We initially started off with 10 milligrams per kilo. Now we know that 5 milligram per kilo is equally good, much more specific. It's a monoclonal antibody to TNF alpha, much more specific. Collateral damage is less. The side effects are less as compared to, say, thalidomide, which is much more broader. Side effects is an issue. Will I give high dose steroid? What we normally do is when we see the paradoxical worsening on steroids, I mean, it is not an uncommon scenario. That is when we use an immunomodulatory agent on steroid, they develop paradoxical worsening. You need to start with an immunomodulatory agent. So I probably would have intervened at that time with the evidence now. This is not the same 5 years ago. We would have done probably something very similar. But the evidence is fairly, it is accumulating more and more. Will I have the concern in somebody with miliary TB? So usually by about 2 to 3 months, you have your anti-tuberculous therapy, good doses, taking care of the bacilli, and then you're talking about, you need about that initial 2-3 months. And that is when you see the clinical deterioration with the paradoxical worsening in the CNS. So by then, the miliary problem would have vanished, meaning the good ATT that will take care. Here, it's a confined space, blood-brain barrier, all those with the inflammatory response by the host is doing more damage than anything else.
Just to wind up, can I ask Dr. Muthugala, this patient had been given the BCG vaccine and it's meant to protect us from extrapulmonary TB. So can you speak a bit about that?
Yes, actually BCG vaccine main aim is to prevent disseminated tuberculosis and the TB meningitis in children. The efficacy is around 60 to 80% depending on the endemicity in the children. But in adults, there's no evidence, conclusive evidence for BCG will protect any pulmonary TB or reactivation of tuberculosis. The only indication for the adult to give BCG vaccine is if you're going for a laboratory or treatment center with TB patients, or if you are going for a high endemic country with leprosy or tuberculosis, it's indicated. But there's no other indication for BCG in adulthood.
Okay, so we'll, in interest of time, we'll stop there. Thank you very much, Dr. Pavitra.
Thank you.
May I now invite the second presenter, Dr. Suresh Kumar, who will discuss the next case.
Good afternoon, respected consultants, ladies and gentlemen. I would like to express my heartfelt gratitude to the Ceylon College of Physicians for giving me this opportunity to share this intriguing case presentation in which a seemingly healthy young adult has undergone a devastating transformation. Let us unfold the mystery. Our patient is a 23-year-old male who's a student, and 5 months before he came to us, he has had an acute febrile illness with cough and shortness of breath and a generalized macular rash. He was admitted in a local hospital during this time, and after treatment, he had recovered in 2 weeks. He then came to us with a 5-day history of reduced speech, confusion, reduced mobility, and generalized tonic-clonic seizures. He didn't have any fever, headache, photophobia, phonophobia, and there was no focal weakness or numbness. He didn't have any history of drug overdose, no vomiting, bladder or bowel complaints, and his systemic review was normal. His past medical, past surgical, and allergy history was unremarkable. He was a non-smoker, teetotaler, and there was no history of substance abuse. His general examination didn't reveal any pallor, icterus, cyanosis, lymphadenopathy, clubbing rashes, or pedal edema. He had a blood pressure of 120/80 and was slightly tachycardic with a heart rate of 102 per minute. He had a dual rhythm on auscultation with no murmurs or bruise. He had bilateral equivalentry with a saturation of 98% on room air. Abdomen was soft and non-tender. His neurology examination showed a GCS of 13/15, which progressively reduced during his admission. He was afebrile on touch. There was no neck stiffness. Pupils were bilaterally equally reactive to light. There was no disc edema on his fundoscopy. Limb examination was also normal, with both upper limbs and lower limbs showing a bilaterally normal tone, power 5/5, and reflexes 2+, and lower limb examination showed downgoing plantars. Sensory examination, cerebral examination, and cranial nerve examination were also normal. What's interesting was this involuntary movement observed over his face.
Let me stop you there. As we are seeing the video, can Professor Chang please explain to us what we're seeing? There are a few more videos.
Yes, madam.
So here, of course, you can see this periocular sort of involuntary rhythmic sort of movements.
Show the next video.
So it's there. You can see a brow beating and a quite the eye ocular movements. It's quite rhythmical, involving the upper face.
There was also an involuntary movement noticed over his distal limb.
These are myoclonic movements.
Not very typical of a myoclonic movements, but yeah, that on one side. Not very typical, but
Okay, we'll move on to the EG and investigation.
At the end of the history and examination, we considered infections, immune-driven causes, metabolic and toxin-related causes as the reason for his altered behavior, reduced speech, and abnormal movements. We proceeded with the investigations. To begin with, the full blood count showed a WBC of 10.76 with a hemoglobin of 13 and platelet of 183. His inflammatory markers were elevated. CRP was just 10, ESR of 10, and procalcitonin of 0.12. And moving on to his metabolic screen, sodium was normal, and so were his other electrolytes. His thyroid function test, liver function test, renal function tests were also normal, and his serum ammonia levels were also normal. So this helped us in excluding metabolic causes as the reason for his deterioration. Still keeping infections on mind, we proceeded with a CSF analysis, and we noticed that was also normal. There was a traumatic tap with the red cells of 100 and lymphocyte of 1, but his protein level was 45 and there was no evidence of sugar drop. As he had generalized tonic-clonic seizures, we proceeded with an electroencephalogram, which is shown. And he had also undergone an MRI brain. He was given intravenous and oral anti-seizure medications, but despite that, he had persistent drowsiness and myoclonic movements. He was managed for a possible autoimmune encephalitis, and he was started on intravenous methylprednisolone.
Professor Chang, can I ask your thoughts on up to now of this case?
So now here you have a young patient, 23 years old, coming with a cognitive deficits. There is a slow cognitive deficit. And he's had a generalized tonic-clonic seizure. You can see orofacial sort of dyskinesias and some movement in the hands, which looks like a very slow tremulous sort of or a myoclonic sort of movement. So in that context, the first diagnosis that comes to your mind, and especially with all the blood tests being normal, all the bloods normal, CSF unremarkable, the first diagnosis that should come to you is NMDA receptor antibody encephalitis. So that is the usual progression of NMDA receptor antibody encephalitis, where you will get cognitive changes, psychological changes, seizures, and reduced level of consciousness. And what is most striking in that sort of condition are these movement disorders. So in a patient with reduced level of consciousness having movement disorders, always consider the possibility of NMDA receptor antibody encephalitis, because that is a very treatable condition. So in this patient, everything falls into that. The EEG can be passed off as, showing his seizure activity. So the EEG is not very specific in NMDA receptor antibody encephalitis, except that you may get what is called a extreme delta brush, which occurs in about 30% of patients, but this is not what it is. This is just showing a very disorganized seizure activity. The MRI is non-specific because you saw those signal changes occurring in both the hippocampus, in the cortex, on the left side in the parieto-occipital region. So you can have non-specific MRI findings in patients with NMDA receptor antibody encephalitis. So autoimmune encephalitis would be the first consideration because it's a very treatable condition, and very rightly they have treated the patient with intravenous methylprednisolone.
After starting treatment, he still had worsening drowsiness with persisting myoclonic movements. On day 3, he required transfer to the ICU with ventilation and EEG monitoring. Despite midazolam infusion, his movements persisted. EEG discharges also persisted. He was then started on plasma exchange and 5 cycles were given, followed by intravenous immunoglobulin and IV rituximab. However, this was his condition when he was in the ICU. You can see he's intubated and he had the persistence of these involuntary movements involving his eyes and forehead. He even had persistence of the movements involving his distal limbs. And his fever chart revealed hyperpyrexia while he was in the ICU. There was also a lability of his blood pressure and heart rate, suggestive of dysautonomia. At this point, further workup was done. His CSF studies include negative TB gene expert, HSV-PCR, VZV-PCR, retroviral VDRL, hepatitis B and C antibodies were negative. His CSF NMDR antibody was also done, which was negative, and he had a negative ANA. Considering a possible paraneoplastic etiology, CECT, neck, chest, abdomen, and pelvis was done, which was negative. Ultrasound testis was normal, and tumor markers were negative. His serial EEGs were done. The first one was on the day 5 of his NICU stay. This was his EEG done on day 8. This was done on day 11. This was on day 13. This was on day 15, day 17, and this was on day 24 of his NICU stay.
Is there anything new that's appearing on his EEG now?
Yeah, so now when you look at the whole case, it's still, this is something, I want to emphasize to you is never to miss a NMDA receptor antibody encephalitis, because if treatment is started late, then it is going to lead to irreversible brain damage. So this is a condition, even if you make a mistake, overdiagnosis is all right, because if it's the case, then the patient should respond. So very correctly, they have treated the patient because everything fell into NMDA receptor antibody encephalitis. A young person having orofacial dyskinesia, reduced GCS, having all these movement disorders. Dysautonomia is a feature of NMDA receptor antibody encephalitis. So you have the early phase, you have the late phase. So early phase, you have cognitive, psychiatric, and seizures. In the later phase, untreated, they have a coma, movement disorders, and dysautonomia. So this is what you look for, and this patient fulfilled all that. But what was atypical is that even after all that treatment, the patient had methylprednisolone pulses. The patient had IVIG, the patient had plasma exchange, and rituximab. Rituximab is a fantastic medication because now it doesn't have a patent, it's fairly cheap, but it's an anti-CD20 and it works wonderfully well for NMDA receptor antibody encephalitis. So much so that we now use it as first line because it is so effective. So despite all this medication, you can see that the patient is actually progressing. And what is atypical about this whole case is, although everything fits into autoimmune encephalitis, the EEGs are not keeping with it. Now in the EEG, generally in autoimmune encephalitis, the EEGs you will see is generalized slowing, or you will see this extreme delta brush in about 30%, or in some you will see a normal EEG. But this is a very, very abnormal EEG that they have carefully documented and repeated serially. And as you can see, now it's assuming a pattern. Now here you can see periodic discharges that are occurring at about 2 seconds. You get these high amplitude delta waves. Now that is very unusual for autoimmune encephalitis or NMDA receptor antibody encephalitis. So that, and the patient's cognitive decline continues, and the patient is actually not improving, getting worse, needed ICU care. So now you need to think of an alternative diagnosis with this EEG. So now you reverse the diagnosis and think this cannot be an NMDA receptor antibody encephalitis. This is something else that is causing these EEG changes.
So then we did some further investigations, and considering this abnormal EEG pattern of the periodic high amplitude discharges, we considered whether this could be SSP, which was related to measles, and sent the CSF measles antibody. And it turned out that his IgG was positive at a low titer. And considering that 5 months ago he has had an acute febrile illness with a maculopapular rash, we traced his previous medical records, and it turned out that his serum measles IgM antibody was positive at that time during that episode. His other investigations done at that time include the EBV serology, ASO T titers, HSV, CMV PCR, and retroviral screen, which were all negative. It was surprising for us for this patient to have a positive measles antibody, and we looked into his immunization history. But to add to the mystery, he has received his MMR vaccine at 9 months and 3 years of age.
I'd like to ask Professor Varghese now what he would be thinking of at this stage.
Although you considered SSP as a differential or a possibility, to me there are several things which are not fitting in. Number one is usually SSP occurs several years down the line, usually 5 to 10 years after the measles infection, the SSPE occurs. And it's a slow onset disease, cognitive decline, poorer scholastic performance, and it slowly, manifests. Usually children going on to adolescence, and this kind of acute presentation and features makes me wonder whether it's SSPE itself, because I think that I would consider less likely. But you've proven that there is, he had measles about 5 months ago, both clinical manifestations and IgM antibody, which was positive. All that put together, probably he has had measles at that time, although he has had a vaccine during his childhood. At 9 months of age, he received a measles vaccination. But it's very well known that the antibody levels go down for measles by adolescents, and therefore people even talk about, do they need a booster? And I don't know how common it is in Sri Lanka to give MMR vaccine boosters later on. In several developed countries, they do that. So I'm not surprised that he had a measles, 5 months prior to this illness, in spite of having 1 dose of measles vaccine at 9 months of age. But what I'm surprised is that it doesn't really fit in with SSP. What I can think of, which I have never seen, I've seen few cases of SSP, which has all been the subacute to chronic presentation, very insidious in onset, and never an encephalitis like this, acute encephalitis. The only thing which I can really think of which could fit in very well is the measles inclusion body encephalitis. Measles inclusion body encephalitis is again can present like this acutely, usually about 5 to 6 months after a measles. They can have, severe encephalitis which is progressing, and it's the virus which is multiplying in the brain. So could that be a possibility here? I would think that could be a possibility given the temporal profile of probable measles, which is almost definitively diagnosed at that time, 5 months before, and the manifestations now. I would think that the measles inclusion encephalitis is more likely here. Would I consider other causes of encephalitis? You've looked at the common ones, but the other caveat is that even in literature, the measles inclusion body encephalitis is more common in immunocompromised individuals, say HIV infected or those kind of individuals are not able to control the virus. It progresses, the virus continues to multiply and causes problems. So here it was an immunocompetent individual. That was the feature against this thing. The other encephalitis which could, the other causes of limbic encephalitis you would looked at, you've looked at the malignancies are common. Autoimmune encephalitis, which was in details explained. You have looked at many of those causes and it's ruled out. Among the infections, HHV6 is something which one may see in immunocompromised individuals, particularly in the post-transplant setting and all that, but limbic encephalitis in those kind of setting. So this is not the host where you would see that. And I wonder whether the other encephalitis like JE or some of those, are they seen in Sri Lanka? Or, and I know that you have not looked at those causes. Maybe you're not seeing it. Or maybe we should we look at it? So if we have to put everything together, the measles 5 months ago and now, I would say that probably it's measles inclusion body encephalitis.
Have anything to add, Professor?
Yeah, no, from a very simple neurologist perspective, when we see that sort of EEG, that is almost pathognomonic of SSP, because when you get this periodic discharges, high delta wave discharges, so that is almost pathognomonic. It is time locked with the myoclonic jerk. So although this boy's jerks, the myoclonus was not very typical, because myoclonic is like a shock, like you see this suddenly shock-like movement. So that is not what we actually saw. We just saw this like a slow kind of myoclonus. That is kind of time locked with this high voltage, high amplitude delta discharges. And when it occurs periodically, that is because the virus will cause this circuitry and cause these discharges in the brain. It has this periodicity that is, no one has actually explained now. I still remember we see patients where it occurs spot on at 8 seconds. Every 8 seconds you will get this discharge, right? Why it occurs at every 8 seconds? It clusters around 8 seconds and no one really knows. But the range is given between 4 and 15 seconds is the range that you get this clustering of these discharges. Now, the other DD that comes to this is like CJD. In CJD, the EEG, you get this discharges, but less than 4 seconds, the periodicity, usually at about 2 seconds. So when it's between 4 and 15 seconds, clustering around 8 seconds, for us it's kind of pathognomonic of SSP. But like Prof. George said, it's very unusual for it to be so aggressive. So we are thinking of a kind of the usual thing that we see is the slow, indolent sort of, it creeps on the patient, there is a cognitive decline, then the patient develops a little, once a cognitive decline occurs, you notice a little myoclonic jerks and things start going downhill. But this is a kind of a fulminant sort of presentation. So whether it's an inclusion, thing, or whether it's a fulminant form of SSP is what we think of. But given that EEG, we put all our money on the SSP because that's so characteristic, so typical pathognomonic of SSP.
I'd like to ask Dr. Muthugali, is there any treatment options of, in terms of antivirals or for the SSP, yes, or even if it's inclusion?
Yes, actually now they were targeting on the antiviral treatments, ribavirin, then the famivir, then remdesivir, and also sometimes they can target the interferon treatment for immunosuppression as well. But the thing is, all these treatments only slow down the progression of the disease. There's no cure for the disease, for if it is SSP.
It is fatal.
Fatal, yes, invariably fatal. So I also agreed with our other colleagues, considering the clinical history, the timeline, and the investigations. It's more unlikely this could be SSPE. Probably one reason could be the inclusion body measles encephalitis, or we are having the J. Although the number is very less in these days, but J is endemic in Sri Lanka. But considering his age, he should have get the JE vaccine. That may be another concern on this case. Also, sometimes West Nile virus. There were a couple of reports reported in Sri Lanka. Or maybe even unknown arbovirus. Maybe we were not detected in the country, maybe a possibility.
So, this particular patient has had the measles vaccine. Can you, because in this day and age now there is a hesitancy to get the measles vaccine as well. There are pockets of certain groups of population in Sri Lanka who are not taking the measles vaccine. Could you explain a bit about the vaccine and the protection it confers?
Actually, measles, actually the global eradication program is going on. So the WHO is recommending at least we need 95% in coverage for the whole population to keep measles away from the country. So usually in Sri Lanka, the normal immunization program, we give 9 months and 3 years of age of the measles vaccine. But due to this past outbreak, the small children around 6 months of age, and also people who miss the second dose, because we started giving 3 months one is a bit later, so they were offered MMR vaccine. So usually for the first dose, if it is given in 9 months, the immunogenicity, the almost 87% like. So we are giving the third one, in age of 3 years, the second dose, to catch up the rest of the non-immune people, because due to maternal antibodies, there must no seroconversion maybe in the 9 months. So maybe it will get up to 100% after the second dose. So measles is very safe vaccine, but unfortunately, we have found out during last measles outbreak, there are groups belong to certain religious group, extreme groups. They were a little bit hesitant to take the vaccines, not only the measles vaccine. Even after this COVID, there was a bit of a hesitancy against vaccine. I think this is become a big problem for Sri Lanka now, because we need good coverage to control these communicable diseases. Maybe we have to target new approaches to reach out this population and make their attitudes change to get the vaccine. Otherwise, we will see re-emergence of vaccine preventable communicable diseases in Sri Lanka.
Connection with SSP and the measles vaccine itself?
No,
it's very
no.
rare.
It's theoretically it's not possible, because only the wild type of measles virus will cause mutation, this mutation in SSP. But measles vaccine can cause that inclusion body encephalitis, but not SSP.
Shall we see what happened to the patient?
Okay. We thought of treating for SSP at that time and aborted further immunotherapy, and oral ribavirin was started, but he didn't tolerate it for more than a week as hepatotoxicity had developed. And then he was started on intrathecal alpha interferon, that was by the Ommaya reservoir intraventricularly, and 2 doses were given. Oral isoprenosin was also started, and he was given amantadine and clonazepam, and also initiated on a ketogenic diet, which he didn't tolerate, and he was losing weight. His course of the illness during the hospital showed no clinical improvement, and there was persistent of the involuntary movements, myoclonus, of the distal limbs, and also he had the persistent eyelid myoclonus. His MRI was repeated a month later, and it had progressed. There were diffuse T2 flare high signal intensities with areas of diffusion restriction, bilaterally right more than left, in the temporal, occipital lobes, as well as parietal lobes, internal capsule, basal ganglia, thalami, midbrain, and pons. There was also gyriform contrast enhancement in bilateral occipital lobes with subtle letomeningeal enhancement. It was reported as progression of encephalitis with a possible hypoxic injury. We were able to wean him off from the ventilator, but he remained unresponsive. He was on a tracheostomy and a PEG, and his EEG showed persistently periodic complex. His family was explained about the poor prognosis, and palliative care plan was initiated. After 2.5 months of hospital stay, he succumbed while he was in the hospital. The reason I thought of bringing this case was to highlight the importance of the vaccination, and also, although it's not a very treatable condition, it's more preventable, and this type of devastating outcomes must be highlighted to create awareness about the importance of vaccination.
I would like to thank my consultant, my trainer, Dr. Bimsara Senanayaka, and my co-senior registrar, Dr. Arun Rajaratnam, who helped in the management of this patient.
Thank you very much. So I think we've discussed two very interesting cases for this symposium. We have a little bit of time left, for maybe for one question, if the audience would like to ask our expert panel anything.
George, Ramesh from Henry Ford in Detroit. Obviously, this is not my cup of tea because I don't see these things routinely. Does SSP occur much earlier in immunocompromised individuals? There may be some subtle immunocompromise in this young man that was not identified, for example, some sort of T-cell disorder or whatever it is that was identified. Have you seen any? I know that it does in HIV, for example. In HIV and measles, do you see SSP much earlier? Because this looks like SSP, and it walks and talks like SSP. It's just too early.
Yeah. So your question about do you see SSP faster in immunocompromised? In a way, it is true. So we have had one or two patients who, at least one I clearly remember, with HIV infection in the adolescent age developing SSP, confirmed SSP. That also was several years down the line. So I think this is 5 months is too rapid for that. Even if it was advanced HIV infection, I would think that it is little too rapid for this thing. The other pointer here is usually the IgG measles in the CSF is much higher. So here it is very weakly positive. Again, tells you that it's not the typical kind of manifestation. I don't know.
Time's up. Thank you very much to you all for
Thank
that
you.
very interesting discussion.